Thank you. It's exciting to come and talk to everyone about my passion for Aicardi Goutieres syndrome. Uh, Most people don't know about, but my PhD was actually not in neurology, it was in infectious diseases. And this is a disease that actually brings together my clinical passion for leukodystrophies and my prior research passion for herpes viruses. So I am going to present a little bit of data from a study that was funded in part by Eli Lilly, and we also have funding from the AGSAA. So when a herpes virus or any virus binds the outside of the cell, it sets off an entire inflammatory cascade, right? We're supposed to get rid of viruses, and a lot of the machinery that senses a virus sometimes recognizes specific epitopes within the virus, but oftentimes is actually just measuring an imbalance in RNA and DNA. And so AGS turns on the same pathway, right? So when a virus binds, it changes the amount of RNA and DNA in the subspecies within the cell, turning on a robust pro-inflammatory cascade. In particular, type 1 interferonopathies bind to the interferon receptors of all the neighboring cells and turn on then further cascades of inflammation. Some of the genes that are turned on, which we call interferon signaling genes, some of them are pro-inflammatory, but actually a lot of them are anti-inflammatory, because really what the cell wants to do is get rid of the virus as fast as it can and then shut that cascade down. And we see what happens with the devastating early effects of inflammation in the brain. And so babies in utero are particularly susceptible to it. So if you look at this case of congenital CMV, there's devastation in the brain. We call the infections in utero torch infections as a collective group. And neurologically, they actually look really similar. And that's because the injury isn't coming from the virus. The injury is actually coming from the immune system. And so now imagine having every single one of your cells turn on this cascade on its own, right? And that's what Aicardi Goutieres is, which is a sustained inflammatory state where children think they have an infection and they don't, right? And so some of this is triggered by just that natural imbalance because your RNA and DNA metabolism genes are off, and some of it is actually triggered by your endogenous retro elements. So we have moving real endogenous retro elements that make up a sizable portion of our genome. And so that triggers AGS. AGS is actually a collective grab bag of neurologic diseases that activate the type 1 interferon system. There are 9 genes. We're actively discovering more, but they're actually part of a larger group of type 1 interferonopathies, of which 35 have been recognized. The vast majority of them are involved in RNA and DNA metabolism. So I think of AGS as actually an inborn error of RNA and DNA metabolism. And the most common types of cases all fall into the AGS category. The original papers were all looking at congenital torch infections. And if you want to go and look at a really cool historical paper, I love the original paper from 1984 in Annals of Neurology, where Jean Aicardi and Françoise Goutieres did a beautiful job of recognizing an early cohort of where congenital infections were running in families, which we don't see. When a mom gets an infection while she's pregnant, it's actually only the first pregnancy where the child gets really sick. That robust immune response that injures the baby is with pregnancy 1, not pregnancy 2. And they saw that it was actually running in families. And so decade before they discovered any of the genes or even the biomarkers of disease, they postulated that this was a genetic disorder. I see Julie Cohen's getting really excited. She's going to go read the paper. But as is true with every rare disease, once we start adding it to next-gen panels, the spectrum starts expanding. And so what we thought was universally a mimic of torch infection, sometimes AGS is called a pseudo-torch infection. In actuality, it's a really broad spectrum and sometimes with decreased penetrance too. And so if you think of it as having an early onset and late onset form, we certainly get a sizable percentage of our kids present with that pseudotorch infection. You get the thrombocytopenias, the anemias, the hepatitis. These babies look like they have an infection because they have the sequelae of an infection without the triggering virus, right? That's why they look so similar. But then that inflammation doesn't go away. If you have a congenital infection, you have hepatitis or anemia and thrombocytopenia, it resolves. In an AGS, it doesn't, right? You have that sustained drive. We also see late onset forms. So we call anyone that presents with that neurologic decline after 12 months the late onset form of AGS. And those are quite variable in how it affects children. They oftentimes have a period of short normal development during which they have inflammatory symptoms that in retrospect we can see something was going on. Failure to thrive, irritability, they had vomiting, they had feeding intolerance, they had smoldering hepatitis and no one could figure out why. And then in one form of AGS, which is caused by SAMHD1 variants, they can actually get a vascular involvement that's quite prominent, and they can present in later childhood with strokes and moya-moya disease. And so we've picked up several kids with AGS from our stroke clinic. But that systemic burden of inflammation doesn't go away. So regardless of the subtype of AGS you have that continuous systemic drive. And we joke with families, if you have an organ, we need to monitor it because at any point in their life, they could potentially have inflammation and treatable sequelae of this inflammation. And so with this as a background, this being a very atypical leukodystrophy in that it's not a progressive neurodegeneration, but more so these events of extreme inflammation wreaking havoc on the body. We thought there was great treatment potential. This is one of my beautiful patients, and you can see like she walks, she talks, but AGS definitely impacts her life. And so we thought, there are so many genes involved in RNA DNA metabolism, it makes sense to hit further downstream. And so the first medication that we trialed is baricitinib, which is a Janus kinase inhibitor. And then we have been recently trying anifrolumab through clinical use as well, which is an antibody that blocks on the other side of the receptor. There was some early interest in whether reverse transcriptase inhibitors, HIV drugs, could be drug repurposed. I honestly don't think they can. And we're continuing to work with drug companies to potentially find additional rheumatologic targets to help our kids. So in the baricitinib study, what we published so far, which is now 5 years ago in New England Journal, was our pilot data of 30 some odd kids with AGS that we treated for up to 12 months. We now have the full longitudinal cohort. It's up on clinicaltrials.gov. I'm writing the paper. Please give me grace. It's taking a long time. Because we actually combined our 2 cohorts of children that were on the initial compassionate use protocol, and then many of them, because that was closed down, were transitioned over to the phase 2. So it's taken a long time to align that. But we found when treated in the appropriate dose range, which is actually much higher than they use for adult rheumatologic disorders, children are gaining new skills. And they are gaining, on average, 1 major new developmental skill that we wouldn't have predicted they would have gained beforehand, which to a family whose child is profoundly affected, those changes are really meaningful. And if you look at the year before children were treated, there's about a third of kids were declining, about half kids were stable and had no change in their symptoms. And then a small number of kids had a slight gain. And after a year of treatment, we now have most kids were stable or gaining, which is really, really exciting to families. Some kids gained a ton, most kids gained just a little bit. I want to talk about the one kid that declined. That was actually in the context of an intercurrent infection, and outside hospital held the medication for 2 days. That's when your body needs it. And I think that that's a really hard thing for both rheumatologists and infectious disease people. Like these kids, they have a supercharged immune system. You cannot stop their inflammatory blocker in the moment when they need it most. And so that child lost the ability to walk and never regained it. And so these kids have this constant threat of immune pressure. We have some anecdotal evidence that if you treat a younger sibling earlier, they do better. It certainly makes sense. We don't do a great job of reversing injury in neurology, but we do an okay job of preventing it. So our hope is to get kids diagnosed earlier and earlier and potentially initiate treatment before there is injury. I think one of my favorite stories that came out of the baricitinib trial is families were telling us their kids were doing a ton better. We had, of the 50 plus kids, only 1 family chose not to continue it, right? Like families love it. their kids are just less irritable. And they told us what we weren't capturing in any of our standard outcome measures is that their kids, their receptive language and their expressive language was getting better, but not with spoken word. And that's in part because we weren't finding any improvement in the dystonias and the motor dysfunction, which was affecting verbal protection. And so we started to trial, and this is work by Francesca Gavazzi, different measures of IQ in our children with AGS. And if we use a nonverbal measure, so the lighter 3, the vast majority of our children with AGS have IQs within the normal range. And if a child has any degree of independent mobility, they have an IQ that is measurable and normal. So these children are locked in. And our families now take this neurology article and they take it to their IEP meetings, and they're starting to get the schools to give them augmentative communication devices. And so it's just been a really powerful story of listening to families and how much our therapies and our interventions are allowing children to become unlocked. And while we struggle to show huge difference on our scales, there are huge meaningful differences to families. And my kids with AGS that have very limited motor skills are writing stories using eye gaze devices and like novels and comic books and drawing by using augmentative art devices. Like, it's really quite beautiful. With my friend Mike Gelb in the back, we are partnering together to try and get AGS newborn screening up and running. We have good biomarkers in AGS. We can measure the inflammation, but the problem is a lot of things make you become inflamed. And so how do we find a test that's going to be sensitive and specific and not just pick up congenital infection or just vaccination? And so over many years with Asako, who leads the lab part of Adeline's lab, we took samples of patients with AGS, and then CHOP let us take all the clinical samples and go and pick them up at the end of the day and measure interferon testing on them. And through a protocol that allowed us to pull kind of like core traits of the samples. So if the child had cancer and was receiving chemotherapy, if they just happened to get a vaccination, if they were coming in for a runny nose, if it was part of their well child check, we then looked at all the samples and then could stratify. And we identified different signatures of those mRNAs that are being turned on specifically in AGS. And we found really all of them are higher in AGS. Our kids have inflammation that is significantly higher than infection and cancer. And because CHOP does a lot of CAR T therapy, like higher than the CAR T inflammatory response, like these kids have a level of inflammation and a burden on their brain that is just out of control. But if you were to choose one gene, the IFI44L was by far the most sensitive and specific and was almost better than any combination of genes. And if you looked at any other combination of genes, IFI44L was in every single one of them. This is actually a really potent anti-inflammatory ligand. And so what the body is trying to do is turn off the sustained inflammation as hard as it can. And so that's why we think it's measured so high. And so hopefully in the coming years, Mike will, with equal enthusiasm to his other newborn screening talks, talk about how we have newborn screening in development for AGS. So in summary, our struggles with AGS are the same as the struggles we have for all the leukodystrophies. We need earlier diagnosis, we need better interventions, and we need monitoring strategies that both give us the information we need and are evidence-based. And we're working towards that, and it was an honor to be able to present this atypical leukodystrophy to you guys. And I'm pretty proud I also made time, Mandy.